some common cases of acute nephritic syndrome which we see in our clinical practice. Can I use this instead of this? So in our clinical practice, I'll take you to a common clinical case, a 8-year-old boy who comes to you with swelling for the last 5 days, and he has a history of smoky urine for the last 1 day, oliguria, and apparently there was no past history, but there was a history of pyoderma over his scalp 4 weeks back. Now on examination, this child is edematous, he is hypertensive, and on his chest examination is normal. There is no evidence of fluid overload. And investigations reveal that his creatinine is 1.2. He is having almost a nephrotic range proteinuria with a very low C3. His ASO is 400 and his anti-DNase B is very high. So all of us as pediatricians are aware this looks like post-streptococcal glomerulonephritis. And this child was managed with oral diuretics. He was given oral furosemide, and he also required amlodipine for his hypertension. And over the next 5 days, his edema completely disappeared. His hypertension disappeared over the next 2 weeks, and his hematuria also subsided. So he completely responded, and he completely improved over the next 2 weeks. So it was like a typical acute post-streptococcal glomerulonephritis. So what is a nephritic syndrome? So as we are aware, there are PGs here, and we need to differentiate nephrotic from nephritic syndrome. Now what is nephritic syndrome? It's defined as an abrupt onset of hematuria, which can be gross or microscopic, with proteinuria, with CAS on the urine examination, with hypertension. So for PGs here, I would say hematuria, proteinuria, hypertension. So these 3 things. Remember, gross hematuria is rare in nephrotic syndrome. So very rarely you'll see gross hematuria in nephrotic syndrome. So gross hematuria or microscopic with proteinuria, with CAS, hypertension, and they may have a variable degree of renal insufficiency. Now, what are the etiologies? Most commonly, we see post-streptococcal or post-infectious glomerulonephritis, but you should also remember that there are many other causes of glomerulonephritis which are non-infectious, like primary glomerular disorders like PSGN, IgA nephropathy, or it can also be a part of vasculitis like Henoch-Schönlein purpura, microscopic polyangiitis, lupus nephritis. So we should be, in your history and examination, you should be looking at pointers which may point towards vasculitis or lupus nephritis or Henoch-Schönlein purpura. Now almost many decades back, PSGN was described as in children who used to have scarlet fever, and after an episode of scarlet fever, they used to have albuminous and exudative urine. So then they discovered post-streptococcal glomerulonephritis. But streptococcus as a cause of PSGN was discovered almost 50 years after that. So it is important to understand that all glomerulonephritis is not post-streptococcal. And nowadays, we call it as post-infectious glomerulonephritis, which is defined as immunologically mediated glomerular disease triggered by a non-renal infection, most often with streptococci, but remember, many other organisms can also cause post-infectious glomerulonephritis. And many things have changed regarding post-infectious glomerulonephritis in the past few decades. And the most important thing is the demographics have changed. Now, all of you know that, in the last many decades, we used to see more and more of PSGN. But nowadays, in big metros, you see less of PSGN. I live in Gurgaon, Haryana. I see a lot of PSGN still in Haryana. It is very much there. Every week I see a child with PSGN. So it's still there, but less in metros. And we now know there are several organisms which are associated with PSGN. It's not just streptococcus. Now the pathology is better understood. It's not just a serum sickness, which we used to think many years back. And we need to understand that outcomes are not always favorable. As pediatricians always feel PSGN is fine, PSGN will recover. But some of these children do require more evaluation. Now the incidence and prevalence of post-infectious glomerulonephritis varies all across the world. If you look at the developed world, in the US and France, incidence per 1 lakh population is 0.6, 0.7. But if you look in our country, the post-infectious incidence is quite high, of almost 40 incidents per 1 lakh population with a high prevalence. Trends have shown that nowadays post-infectious is reducing. If you look at Singapore, in 1970s, they used to see a lot of post-infectious. But in the last 4 decades, it has reduced. But in our country, we still have PSGN, and I used to think that it's rare, but I still see in my state a lot of PSGN every week. So there are many other infections. There are many bacteria, fungi, viral infections, helminths, even protozoa, which can cause glomerulonephritis. Most of these children do not require a kidney biopsy, but if we do a kidney biopsy for a specific indication in these children, kidney biopsy may vary from diffuse exudative, so which means you can have a big glomeruli with endocapillary proliferation, diffuse neutrophils within the glomeruli, with segmental crescents. You may have mesangial proliferation, or they may have a MPGN kind of pattern. Okay, so they may have a big clusters like this also. So they may have different patterns. And classically, it has been described that the immunofluorescence gives us the diagnosis. Most of the times here, we don't need an electron microscopy. They have a classic granular pattern, a starry sky, or a garland pattern of C3 and IgG. So they have a granular appearance on immunofluorescence. On electron microscopy, these abnormal antigens cause subepithelial humps. So they are diagnostic. If you do an electron microscopy in a rare case, you'll find humps in these children. Now, what is the pathogenesis of post-streptococcal glomerulonephritis? And there are many pathogeneses. The most commonly thought of was an immune complex mechanism, or these streptococcal antigens or other antigens may cause a direct toxicity to the podocytes, or a molecular mimicry kind of mechanism like we see in rheumatic fever, or an intracellular effect of these antigens. And the most common pathogenesis appears to be that there is a nephritogenetic antigen, and normally it is not able to enter the podocyte and the endothelial layer because of the negative charge. But suppose we have a patient who is already predisposed to get PSGN. This nephritogenetic antigen binds to the antibody, leads to the liberation of enzymes like collagenase and MMP, and this nephritogenetic antigen comes into the podocytes, and this is what causes the subepithelial humps. And because of the break of the GBM here, these patients will also have proteinuria and microscopic hematuria. Most commonly, we see these patients with hypertension. They present like a classic nephritic syndrome with hypertension, edema, gross, cola-colored urine. But remember, they may have kidney failure of varying degree. They may have nephrotic range proteinuria in almost 10 to 15% of them. Lab, if you do a better test like a streptozyme test, you will be able to capture streptococci in 95% of the cases. And as pediatricians, we are aware, if a child has pharyngitis, we look for ASO titers. If there is a past pyoderma, we look for anti-DNase B. C3 levels are low. In most of them, C3 levels are low, which means that there is activation of an alternative complement cascade. So C4 and C2 are normal. Only preferentially C3 is low, which means alternative complement cascade activation. Now, most of the PSGN improves over the next 4 weeks. Hematuria improves. Hypertension improves in 2 weeks. Edema improves in 2 weeks. So most of the textbooks say that the C3 normalizes in 6 to 8 weeks. But it's important to remember that microscopic hematuria may persist for almost 6 to 12 months. So this is what we tell the parents, that if your child got a PSGN, he may have some microscopic hematuria over the next 6 to 12 months, which is fine. So only if proteinuria is persisting, we talk about biopsy. Otherwise, they don't need a kidney biopsy in these patients. There are specific indications of kidney biopsy, and this is very important for the residents. If you have a patient with acute nephritic syndrome and you do not have a past streptococcal infection, C3 levels are normal. If it's a nephrotic picture, by which I mean there's a nephritic syndrome with a nephrotic range proteinuria. He has rapidly progressive glomerulonephritis. He has anuria, very high urea creatinine. Now, suppose he is not improving. Suppose there's a delayed resolution. His hypertension is persisting beyond 2 weeks. Gross hematuria is persisting beyond 4 weeks. His microscopic hematuria is persisting beyond 1 year. So this may be something else. And I would also mention here that you need to look for systemic features. So if you have a patient with nephritic syndrome with a Hinault-Schönlein purpura kind of palpable purpura, that's HSP nephritis. If you have a nephritic syndrome with features of a malar rash, anemia, photosensitivity, you think about lupus nephritis. And if C3 levels are still low beyond 12 weeks, then this may be another entity called C3 glomerulonephritis, recently discovered. So I'll take you to one more case, a typical patient which we see in our part of the country, a 12-year-old boy who comes to you with gross hematuria, and he has palpable purpura over his lower shins and buttocks. His rash appears in crops, comes and goes, and he also has pain abdomen and arthralgia. And I'm sure all of you know the diagnosis is Hinault-Schönlein purpura. Now on examination, this child is puffy, hypertensive, he has a palpable purpura, and investigations reveal that he has a normal kidney function, but he has a urine analysis showing nephrotic range proteinuria, normal complements, normal ANA. So this is a HSP nephritis, which we nowadays call it as IgA vasculitis. So nowadays we don't call it as Hinault-Schönlein purpura, we say it's IgA vasculitis. And way back in 90s, there was an ACR criteria where they used to talk about age, palpable purpura, pain abdomen, and vessel wall granulocytes. But in 2006, the EULAR, they revised the criteria, and now they say you need to have a palpable purpura and any one of these four, which includes pain abdomen, predominant IgA deposits, arthritis, arthralgia, or renal involvement. It's important to understand that kidneys are very commonly affected in IgA vasculitis or Hinault-Schönlein purpura, and most of the times kidney is involved within 4 weeks of onset and within 8 weeks in 90%. Now there are some studies which used to talk about whether can we give steroids to prevent nephritis. But most of the studies, including a recent study in Pediatrics Journal, they do not support giving steroids to every child of HSP to prevent nephritis. And there's no evidence for that. There are some risk factors who gets kidney involvement, older child, persistent purpura. In fact, I'm following a child right now who has a persistent purpura since last 2 months. And now he has started to develop some hematuria, severe pain abdomen, decreased factor 13 levels, or a relapsing pattern. Now HSP is just like IgA. So you look at mesangial proliferation with mesangial deposition of IgA, and even on electron microscopy, we see mesangial deposits. So remember, it's like IgA nephropathy, it is a mesangioproliferative deposits with IgA deposition in them. Now the guidelines, there's not much evidence on how to treat these children, but it's important to note that children who have severe involvement, a child with severe pain abdomen should get steroids. So in our institute, we do see children with HSP with severe pain abdomen, and after ruling out other causes of pain abdomen, we do give them steroids and they improve. A child with orchitis, nephrotic syndrome with HSP may also require steroids with other immunosuppressants like oral cyclophosphamide. And if a child presents with rapidly progressive glomerulonephritis, we may need to give pulse steroids and give him IV cyclophosphamide. Rarely these children may present with pulmonary bleeds where they may respond to plasmapheresis. And just one more case which is very important. So coming back to this child was biopsied and he had crescents on his biopsy, and which were IgA positive. So these were immune complex crescents. We gave him prednisolone because he had nephrotic syndrome, and we also gave him oral cyclophosphamide, and he completely improved. Now, last case is a very important case. This is a 12-year-old boy who came to us from Madhya Pradesh, and he had breathlessness, cola-colored urine, and he was on oxygen. He was hypertensive. So remember, he was on oxygen. and his hemoglobin was 5, platelets were normal, his creatinine is 2.5, urine is full of RBCs. So this is not hemolytic uremic syndrome. His platelets are normal. There is no evidence of hemolysis. So can anyone tell me? I'll show you the X-ray. What is this patient having? So this patient, as on the X-ray, you can see he has some fluffy shadows over the lower lobes here. So you should suspect pulmonary hemorrhage in patients who present to you with GN with a low hemoglobin. We have missed many cases in our lives, and we have lost also some children because pulmonary hemorrhage was missed. This is a CT scan showing diffuse alveolar hemorrhage in a case of vasculitis. So this child appears to be having a vasculitis causing a rapid acute deterioration of the kidney function. So we did the biopsy in this child, and the biopsy showed 100% cellular crescents. All the crescents were cellular. They were not fibrous. They were cellular, 100%. And on evaluation, his ANA was normal. His C3 complements were negative. His ANCA was positive. So the diagnosis, anti-GBM was negative here. So diagnosis is a rapidly progressive glomerulonephritis and ANCA-associated vasculitis with diffuse alveolar hemorrhage. So it's important. This is very important because sometimes we tend to miss that. And we say it's all because of pneumonia, while it is actually pulmonary hemorrhage. So just 2 more minutes I'll be taking. What is RPGN? It's defined as a patient who has a typical nephritic syndrome, plus he also has rapid deterioration of the kidney function. Okay, which means that his kidney function has rapidly progressed over days to weeks, which means his GFR has reduced to more than 50%, and most of these children have crescents on their kidney biopsy. So sometimes we say it's RPRF, rapidly progressive renal failure. So remember that sometimes hemolytic uremic syndrome can also present like this. I have a child right now in my ICU who had a typical nephritic syndrome, but he has hemolytic uremic syndrome. He's actively hemolyzing. Even acute nephritic syndrome can also present like a rapidly progressive renal failure. So for PGs, RPGN is a part of RPRF. Okay, so if you have a rapidly progressive renal failure, one of your differential is rapidly progressive nephritic syndrome. And rapidly progressive nephritic syndrome is an emergency. So when I was a fellow, we were supposed to do a biopsy on the same day. If the child is stable, we had to do a biopsy and we had to look for crescents on the same day. So we would ask our pathologist that he should not go home, and late in the evening we would look at the crescents and start therapy the same day. So it's an emergency like other emergencies we see in pediatrics. So rapidly progressive glomerulonephritis can be immune complex, where you can have complexes of post-infectious glomerulonephritis. You can have IgA deposits, lupus full house deposits in these patients, or it can be, you can have pausiimmune, which can be microscopic polyangiitis, Wegener's, a renal limatic, or it can be anti-GBM, which is quite rare in children. So remember that all these children require ANCA, ANA, complement panel, and biopsy in specific situations which I just mentioned. Anti-GBM should also be done in children, and nowadays we have line immunoassays. We can do a line immunoassay which looks at anti-GBM, ANCA on the same test. So remember that children, these are multiple studies looking at RPGN in children, and most of them are immune complex. Now this is a study from All India Institute where they found that pausiimmune is as common as immune complex. So if you ask me, I see more of pausiimmune crescentic GN in children, and it's equally common as immune complex. And in children, we do see that these children do have other features like fever, anorexia, weight loss. They may have other constitutional symptoms as well. Management of this vasculitis is completely different, because if a child has severe life-threatening involvement, we may need to give him pulse steroids followed by oral steroids, and we give him IV cyclophosphamide. And especially children who are having dialysis dependence, this is adult study. So those children who are dialysis dependent ANCA vasculitis should get plasma exchange. Children with diffuse alveolar hemorrhage should also get early plasma exchange. So I'll not take into the details, but we have an induction regimen for vasculitis followed by a maintenance regimen. And the induction regimen talks about monthly cyclophosphamide, methylprednisolone, followed by maintenance prednisolone. And we maintain it with azathioprine with prednisolone. Now, remember that according to the American Society of Apheresis, ANCA-associated vasculitis, which is dialysis dependent, or diffuse alveolar hemorrhage, is a grade 1 evidence to give plasma exchange, as it is anti-GBM disease. So I would just highlight these two. These are specific indications for plasma exchange in these children. I'll take you back to this child who came to us from Madhya Pradesh. We could diagnose this pulmonary hemorrhage because we have missed some cases also in the past. And this child was started on plasmapheresis, pulse methylprednisolone, and he improved. So to summarize, I would just mention that nephritic syndrome is a common cause, and it is very commonly one of our referral for which we are referred. Post-infectious appears to be the most common cause, but things have changed, and post-infectious, there's a change epidemiology. Now developed countries see a different kind of post-infectious. Outcomes are usually good, but if it is not improving, we should be looking at some other disorders like a C3 glomerulonephritis also. RPGN, a child who has a FU nephritic syndrome with rapid deterioration of kidney function, is an emergency, and we should be looking at an early kidney biopsy in these children to find the cause and treat them with an aggressive early therapy, because there's a significant risk of ESRD and death in these children. Thank you.